Lines of Zahn. You remember that? I'm pretty sure you've heard of it. Take a look at this. You could see it right here. I bet you're checking it out in this image. Wow. Interesting. We'll see this and a lot more later on. My name's Dr. Anthony Wheeler, and I'm going to tell you everything that you need to know about pathology. Let's get started. In this discussion, we're talking about thrombosis and embolism pathology. Make sure you have your book. Take notes, write everything that you need to do exceptionally well on step 1, even though it's pass-fail now. That's a good thing or a bad thing. Either way, you need to take advantage of the time that you got and do your best. So make sure you have this book. It's paired with all these presentations, right? Thrombosis, the pathologic development of an intravascular blood clot, may result in a thrombus. Thrombosis may occur either in arteries and or veins. The deep veins in the leg below the knee are where they often are found, okay, right? So, for example, you get the classical clinical vignette of a middle-aged male who's been driving in a truck for a very long time or had to take a flight from New York City to Los Angeles and has been sitting for a while, then has extreme pain in his legs. It's looking swollen and red and warm. They might have trouble breathing, right? You should have PE on the differential. But I'm getting ahead of myself. Let's start off with this here. An antemortem thrombosis is characterized by lines of Zahn and adhesion to vessel walls. Now this image here to the right shows lines of Zahn. It's highly likely that you will see this, so make sure you understand what it looks like and make sure that you remember that it occurs when there's clot development during the living situation. Let's just put it that way. Lines of Zahn are alternating layers of platelets and fibrin in red blood cells. Keep in mind that postmortem clots are not attached to the vessel wall and do not have lines of Zahn. Autopsy pathologists or forensic pathologists utilize the lines of Zahn or just random clots to determine whether the patient died before the clot happened or afterwards. Blood flow disturbance, endothelial cell injury, and a hypercoagulable condition are 3 key risk factors for thrombosis, which are described by Virchow's Triad. This image is showing cyanosis of the right distal foot due to an occlusion caused by acute arterial thrombosis of the right leg. Can you tell the difference between the feet? All my budding radiologists out there, neuroradiologists, what's happening in this image? We see an acute thrombus in the right middle cerebral artery. Here's another example of an occlusion due to a thrombosis. Even in Kawasaki disease, you know that cherry red tongue. All pediatricians should know this, and future budding pediatricians. Let's talk a little bit about disruption in normal blood flow. Blood flow turbulence and stasis raise the risk of thrombosis. Laminar blood flow, which is typical, keeps platelets and other components scattered and inactive. Potential causes of disruption in normal blood flow include immobilization, which increases the risk of DVTs, like our middle-aged male friend that was riding on the plane, or cardiac wall dysfunction, such as arrhythmia or myocardial infarction, or aneurysms, Endothelial damage disrupts endothelial cells' protective role, raising the possibility of thrombus. Multiple mechanisms are used by endothelial cells to actually prevent thrombosis, which include reduce exposure to underlying tissue factor and subendothelial collagen, the creation of prostacyclin 2 or PGI2, nitrous oxide production to keep those vessels vasodilated, platelet aggregation inhibition to keep platelet aggregation from forming, the release of compounds similar to heparin to stay anticoagulated that boost the antithrombin international units ATI enzyme, which renders thrombin and coagulation factors inactive, the secretion of tissue plasminogen activator, which changes plasminogen to plasmin, cleaves the fibrin and serum fibrinogen, destroys the coagulation factors, and blocks platelet aggregation, and the secretion of thrombomodulin, which causes thrombin to be redirected to activate protein C, deactivating factors 5 and 6. Let's talk a little bit about endothelial cell damage specifically. Now, this damage to endothelial cells are brought on by a number of issues, including vasculitis, atherosclerosis, and elevated homocysteine levels. Here in this image, we can see endothelial cell damage. Low levels of folate and vitamin B12 raise homocysteine levels, which raises the risk of thrombosis. Side note, what will neutrophils look like when there's low levels of folate and vitamin B12? Will they be hypersegmented? Yes, they will. You must know that because you will see it. Back to endothelial cell damage. Tetrahydrofolate, or folic acid, circulates in the blood as methyl tetrahydrofolate. Cobalamin, or vitamin B12, receives a methyl transfer, enabling THF to take part in the production of DNA precursors. Methyl is added to homocysteine by cobalamin, which produces methionine. Homocysteine builds up because the conversion of homocysteine to methionine is reduced when folate or vitamin B12 deficiency is present. Makes sense? I know that's a lot of biochem. You can pause it if you need to revisit that. Homocysteine levels are high and homocysteinuria occurs as a result of cystathione beta synthase deficiency. This is another way that homocysteine levels can be increased due to cystathione beta synthase deficiency. Homocysteine is converted by cystathionine beta synthase to cystathionine. In the presence of in the lack of the enzyme cystathionine beta synthase, that causes an accumulation of homocysteine. Makes sense, right? Because if you don't have the enzyme that converts the beginning product to the end product, then you'll just have the beginning product. You shouldn't even call it a product. Now, what about a hypercoagulable state? Well, that state's fundamentally in the name. A hypercoagulable state may be due to an excess of procoagulant proteins or defective anticoagulant proteins. Hypercoagulable states may be inherited from mommy and daddy or acquired out there in the real world. Recurrent deep vein thromboses in children is an example of the classical presentation of an inherited hypercoagulable state. This usually happens in the deep leg veins, but it can also happen in the hepatic and cerebral veins. The autosomal dominant protein C or S deficiency reduces the coagulation cascade's negative feedback. Factors 5 and 7 are often deactivated by proteins C and S. Because of their shorter half-lives compared to factors 2, 7, 9, and 10, protein C and S experience a transitory shortfall during the first stage of warfarin therapy. That's why we give a warfarin and heparin bridge, right? Because warfarin acts so fast on protein C and protein S that those enzymes are basically diminished to the level where they can't stop the factors that are still promoting coagulation. So you have these abnormal clots being present, causing warfarin skin lesions and issues, right? That's why we give the heparin bridge when we give warfarin. When warfarin therapy is started in patients with pre-existing C or S deficit, a significant deficiency is present, increasing the risk of thrombosis, particularly in the skin, causing warfarin skin necrosis, as you can see here in the right. A mutant of factor 5, called factor V Leiden, lacks the cleavage site needed for protein C and S to deactivate it. This is the most frequent hereditary factor for hypercoagulability. A hereditary point mutation in prothrombin called prothrombin 2021OA or 2021OA leads to enhanced gene expression. Increased prothrombin causes a rise in thrombin, which encourages the formation of thrombus. A lack of AT3 increases the risk of thrombus by reducing the proactive action of heparin-like molecules generated by the endothelium. And in the right here, we can see a patient who's experiencing a DVT in their right leg. Can you tell the difference between the two? Notice how the one on the right is swollen, a bit red. So if you're in the ED working, you should be on the lookout for this. Note that heparin-like substances typically cause ATI to be activated, which renders thrombin and coagulation factors inactive. And that's probably antithrombin 1 specifically. In antithrombin 3 deficiency, PTT doesn't increase with standard heparin dosing. Pharmacologic heparin functions by interacting with and turning on antithrombin 3. Coumadin, aka warfarin, is then administered to maintain an anticoagulated condition after high heparin dosages activate minimal antithrombin 1. A hypercoagulable state is linked to oral contraceptives. The increased generation of coagulation factors caused by estrogen raises the danger of thrombosis. And here in this image, you can see a number of occluded vessels, whether it's due to atherosclerosis, ruptured plaque, or thrombus organization after recanalization. Speaking of which, let's get into embolisms. An embolism is an intravascular mass that moves and obstructs downstream vessels. Think of a river. What would happen if you barricaded that river with a dam? You'd have obstruction of flow. An embolism is obstructing the flow of blood from getting downstream. Embolism symptoms depend on the vessel involved. For example, if you have an embolus in your lower leg, you'll probably notice it obstructing blood flow to your foot. If you have an embolism in one of your coronary arteries, you'll probably experience left-sided radiating pain, extreme chest pain. If you have an embolism in your middle cerebral artery, you'll probably experience some stroke-like symptoms, right? It depends on where the embolism is located. Note that a thrombus that dislodges is the cause of thromboembolism. Now, you can have many types of emboli, and those include a thromboembolism, which is the most common, atherosclerotic embolism, which will have cholesterol clefts, a fat embolism, which will contain adipose tissue, gas embolism, which can be seen in divers, people under pressurized conditions, and amniotic fluid embolism, such as in a pregnant female that gives birth. Let's talk a bit about each of those varying types of embolism. With regards to the thromboembolism, it has a 95% prevalence compared to the other ones. Thromboembolism is regarded as the most prevalent kind of embolus. This image here to the right shows a pulmonary embolism at the bifurcation of the pulmonary artery, that classic saddle embolism. Regarding atherosclerotic embolus, a dislodged atherosclerotic plaque is the cause of an atherosclerotic embolus. As you can see here, the presence of cholesterol clefts, that white, elongated, somewhat lenticular looking space, that's the cholesterol clefts. The presence of cholesterol clefts in the atherosclerotic embolus is what characterizes the atherosclerotic embolus. Regarding a fat embolism, this should be high on the differential after a motor vehicle accident that breaks a long bone in a patient that's having trouble breathing. With regards to a fat emboli, bone fractures, especially lengthy bone fractures, the tibias. Injuries are linked to fat embolism. Fat emboli appear while there is still a fracture or soon after repair. Fat emboli are characterized by dyspnea. Fat, often with bone marrow elements, is seen in the pulmonary vessels, and petechiae on the skin overlying the chest. This embolism is showing marrow elements and fat from the marrow in the pulmonary artery. With regards to a gas embolism is classically seen in decompression sickness. A diver's quick ascent causes nitrogen gas to precipitate out of the diver's blood. The gas embolism presents with joint and muscle pain, i.e. the bends, and respiratory symptoms, i.e. the chokes. Multifocal ischemic bone necrosis is a characteristic of the chronic form of gas embolism known as Caisson disease. Additionally, when air is pushed into the abdomen during laparoscopic surgery, gas emboli can happen. With regards to an amniotic embolism, during labor or delivery, amniotic fluid embolism enters the maternal bloodstream. They may present with shortness of breath, neurological symptoms, and disseminated intravascular coagulation, DIC. Those are the symptoms of this illness. which is brought on by the thrombogenic nature of amniotic fluid. Amniotic emboli are characterized by squamous cells and keratin debris from fetal skin in the embolus. And with regards to a pulmonary embolism, the main cause of pulmonary embolism is thromboembolism. And this image shows a pulmonary embolism. A large saddle embolus is seen in the pulmonary artery. See where those white arrows are pointing? That is the embolus. Deep vein thrombosis, or deep venous thrombosis, DVT, in the lower extremities, typically involving the femoral, iliac, or popliteal veins, is the most frequent cause of a PE. There's also characteristic electrocardiograms for PE. Because the lung receives blood from both the pulmonary and bronchial arteries, it is frequently clinically quiet. The embolus typically shrinks on its own and is modest. Unfortunately, about 10% of pulmonary embolisms result in pulmonary infarction, which happens when a large or medium-sized artery is obstructed in individuals with pre-existing cardiac impairment. The symptoms of pulmonary embolism include shortness of breath, hemoptysis, pleuritic chest pain, and pleural effusion. This image to the right is showing the pulmonary embolism affecting the lung in a patient. A VQ lung scan, short for lung or pulmonary ventilation, and perfusion scan shows mismatch and perfusion is abnormal. On the other hand, a vascular filling defect in the lung is seen on spiral CT in cases of pulmonary embolism. Doppler ultrasonography on the lower extremities can help identify deep vein thrombosis. And D-dimer is elevated in pulmonary embolism. At an autopsy examination, it's revealed that there is a presence of a hemorrhagic or wedge-shaped infarct due to the pulmonary embolism. When both the left and right pulmonary arteries are significantly occluded by a massive saddle embolus, or when a large pulmonary artery is suddenly blocked, sudden mortality can result. An electromechanical dissociation causes death. Chronic emboli that rearrange over time may cause pulmonary hypertension. This image to the right here is a CT scan of the chest performed on admission that showed thromboemboli in the main branches of a patient. Look at all those thromboemboli, even obstructing the main branches and the pulmonary arteries. Wow. Here's another example of an image showing pulmonary embolism. And another. And another. i.e., make sure you understand pulmonary embolisms. With regards to systemic embolism, thromboembolism is typically the cause of systemic embolism, which most frequently develops in the left heart. It is a critical side effect of classical orthotopic heart transplantation. Systemic emboli travels through the systemic circulation to obstruct blood flow to organs, most frequently the lower limbs. This image here to the right is showing examples of systemic embolism. And with that, I hope you were able to absorb some of that information. I hope you were able to absorb all of it. If you have any questions, comments, or concerns, let me know. Make sure you keep studying hard. Keep at it. I know it's a lot, but you got this. I'm here to support you. Make sure that you have everything that you need to succeed. You're going to do great. Happy studying. Keep up the good work. And I'll see you on the next one. Take care.